Hello, my name is Lori Thomas, and I'm the Interim Director of UNC Charlotte's Urban Institute, where I also serve as the Executive Director of the Institute for Social Capital. It's my pleasure to welcome you to the third in a five-part series of virtual conversations leading up to our annual event in November, the Schul Forum. The theme of this year's forum is economic mobility, which remains ever timely as we are reminded that people who are most impacted by the lack of economic mobility in Charlotte are also those who bear the lingering pandemic's worst economic and physical impacts. The Charlotte Urban Institute has been a part of a community-wide effort to better understand the challenges we face improving upward economic mobility. Our role has been that of a research partner, not only looking at the historical conditions that led to our community's poor ranking, but also at some of the policy solutions that might be the key to building a more equitable and promising future. We are excited to dig deeper into issues and policy solutions through this year's Schul Forum. The forum was established in 2019 with an endowed gift from two longtime supporters of the university, alumnus Marianne Schul and her husband Norm, who served as the Urban Institute's founding director in 1969. The Schuls have long believed in the Institute's power to bring the Charlotte region together in dialogue around important policy issues, especially when the dialogue is informed by research taking place here at UNC Charlotte. And that brings us to our second sponsor of these Schul conversations. In 2019, the Gambrell Foundation made a multi-year commitment to support research at the Urban Institute focused on the issue of economic mobility. An important component of that research is the Gambrell Faculty Fellows, a program that funds faculty who are committed to exploring more deeply how issues within their respective fields might further our understanding of economic mobility here locally. With these online forums, we're pleased to highlight some of their work. Our next two conversations will focus on the racial wealth gap, featuring Keith Cockrell of Bank of America and economist and racial wealth gap scholar, Dr. Derek Hamilton of the New School. And in October, we focus on workforce development, featuring Janet Labar from the Charlotte Regional Business Alliance and Gambrell Faculty Fellow, Dr. Tianka Crocker. But let's get to today's Schul conversation about health and economic mobility and the bi-directional relationship between the two. It's my pleasure to introduce you to our moderator for today's panel, Dr. Byron White. Dr. White is the Associate Provost of the Office of Urban Research and Community Engagement, Charlotte Urban Institute's parent academic unit. He joined us at Charlotte last year and brings a range of experiences from leading a public-private collaborative at the Strive Partnership in Cincinnati, to serving as Vice President of University Engagement and Chief Diversity Officer at Cleveland State University, Vice Chancellor for Economic Advancement at the Ohio Department of Higher Education, and all following a career at the Chicago Tribune. Byron, I now turn it over to you to introduce our panelists and lead this Schul conversation.
Thank you, Lori. I appreciate that. And thanks everyone for joining us to engage in this really fruitful conversation with a number of really exciting and committed leaders in our community around this topic. I just want to frame the discussion a little bit before we talk with our presenters and our panelists on this issue. A lot of times when we talk about economic mobility, the first thing that comes to mind isn't necessarily health, but as Lori mentioned, these things are intimately connected. The CDC actually estimates that about 90% of the nation's $3.8 trillion in healthcare spending is due to chronic conditions. And those conditions, of course, affect work productivity in very severe ways. Again, according to the CDC, about $45 billion in productivity is lost just due to dental disease, $117 billion for treatment of conditions due to lack of physical activity, $327 billion in annual costs for diabetes is lost in productivity and direct costs. So in concrete terms, you can imagine workers experiencing uncontrolled diabetes, not being able to show up for work every day in those kinds of jobs that might require their daily involvement and engagement, whether in a warehouse or service delivery or other kinds of areas. Children with severe asthma missing school and other vital activities. People lose years of life due to cancer and heart disease that could have been forestalled with healthier lifestyle options. But we know the burdens of poor health are not shared equally across our community. They're really rooted in many of the same inequalities we've been talking about for years and continue to grapple with as a community: redlining, residential segregation, disinvestment in communities of color, racism and discrimination. The Charlotte-Mecklenburg Quality of Life Explorer, which is a joint project of UNC Charlotte's Urban Institute, the City of Charlotte, and Mecklenburg County, lays out some of these factors in graphic terms. And I'd like to just give you an idea of what some of those are. We'll drop in the chat the links to some of these areas and maps so that you can explore them on your own. But just some of the highlights. One map shows proximity to grocery stores, for instance, a key factor in how and whether people can easily access nutritious, fresh food, or whether they're stuck getting what they can in processed food from the corner store or whatever they can transport by bus from Walmart. In another map, you'll see proximity to a pharmacy, a key factor in getting medicine and managing chronic conditions, especially for those people who have limited means of transportation or access to a car. Access to prenatal care for pregnant mothers varies greatly, as you'll see in one of the maps, from over 90% in some places to less than 33%. And maybe the starkest map is really the average age of death and how much it differs by dozens of years in some cases between neighborhoods that are literally just a few blocks away from one another. But what really ties all this together is the final map. And the fact that all of these circumstances correspond closely with demographic characteristics such as race. So why is this the case? We have three experts here to engage us in the conversation around social determinants of health, and more specifically to draw the lines of connection between health and economic mobility for us. Each of them approaches the work through their own lens as researchers, as employers, as administrators. Mostly though, I can tell you that they bring a passion and commitment to desperately work at helping save lives and address inequities in our community. The guests are Dr. Kinneil Coltman, who is at Atrium Health, Dr. Williams at Novant Health, and Dr. Colleen Hammelman here at UNC Charlotte. And so I'm going to give a little more introduction to them and then allow them each to share a little bit about themselves. So why don't we start with Dr. Coltman. Kinneil Coltman is Chief Community and Social Impact Officer at Atrium Health. She leads Atrium's efforts to improve community well-being and their efforts to address the social determinants of health and advance health equity. So Dr. Coltman, welcome, and perhaps you can give us a little bit to introduce yourself.
Yeah, thanks so much, Byron, and please call me Kinneil. I'm really happy to be here. A lot of my role has evolved pretty dramatically post-pandemic. I spent most of my career in healthcare diversity leadership roles and trying to solve for health disparities through that lens. But I think COVID has really given me an opportunity to find new pathways to think about how we extend health equity and to kind of infuse it across the system. So my areas of responsibility here, community health. So a lot of our roving testing and vaccine units that you've heard about during COVID fall under the community health team, community engagement, and corporate responsibility. A newer team that we're calling Social Strategy and Impact, which is really a team whose whole job is to think about social determinants of health all day, every day. We kind of pull that all together so that we're speaking with one voice to the community. And so I'll look forward to sharing more about that work as we get into the conversation.
Great, thank you. Next is Dr. Jerome Williams. He's Novant Health Senior Vice President of Community Engagement. Dr. Williams is a practicing interventional cardiologist, and he leads Novant's efforts to address health disparities in communities across the hospital system's footprint. Welcome, Dr. Williams.
Thank you, Byron. And similar to Kinneil, please call me Jerome. Happy to be here, happy to participate in this discussion. I do have one correction. My title is Senior Vice President of Consumer Engagement at Novant, not Community Engagement. Now, Community Engagement is involved in that body of work. My role is our strategic design, implementation, and monitoring of our community engagement, corporate social responsibility, community wellness, and community benefit programs. And, as we talk about the pandemic and all the effects that the pandemic has had across our community, health, economically, socially, et cetera, it is not lost that a lot of the work pre-pandemic at Novant Health really is focused on addressing the social determinants of health, because we're well aware that 80% of chronic medical problems have absolutely nothing to do with biology, absolutely nothing to do with genetics, but all to do with the environment and behaviors that folks engage in. And this conversation today, as it relates to upward mobility, economic empowerment, economic opportunity is a key social determinant of health activity that really needs to be addressed if we are truly committed to improving the communities that we serve, and look forward to sharing some of the work that we're doing at Novant and across the community in that regard.
Very good, thank you. Our third panelist is Dr. Colleen Hammelman, my colleague here at UNC Charlotte, where she is assistant professor in the Department of Geography and Earth Sciences. Her research really looks at questions of social justice, and in one area, in urban food systems in particular. And she also directs the Charlotte Action Research Project. I'm going to assume Colleen is okay.
Yes, you can call me Colleen.
All right, since I do every day.
Right.
Welcome.
Thank you. So I'll just briefly add. So I'm in the Department of Geography and Earth Sciences. As director of the Charlotte Action Research Project, we're a group that engages with community partners on research projects to produce tangible solutions to neighborhood challenges. And so overall, my research and teaching focus on cities, but particularly social justice in urban food systems. And I'm also currently on the board of directors for the Charlotte-Mecklenburg Food Policy Council. And so mainly the project that I'm going to talk about today is one that I am working with Nicole Peterson, who's in anthropology here at the university, to lead the Food Policy Council's State of the Plate research, which really seeks to take the pulse of the local food system every 5 years. We've been working on this for about 2 years as a result of the pandemic delays. But what we're really trying to do is examine the food organizational landscape for assets, gaps, overlaps, and limitations to address policy recommendations that have come out of past State of the Plate research and other projects. And then also to assess household food insecurity and related concerns, particularly through family surveys. And that's really something that we've been responding to the pandemic and trying to get a handle of what families are doing now. And then I've been primarily focused on that first question around organizational landscape. But following Nicole and I's receipt of the Gambrill Faculty Fellowship, we're also looking into this relationship between economic mobility and food systems. And so have been doing a series of surveys and interviews over the past year with stakeholders across the food system to really dive into this question and understand what that relationship looks like. And I'll talk a lot more about that as we get on, but maybe give a quick teaser that some of the things that are really coming up as we're getting into the data for that is that, food systems are part of mobility through nutrition right? And the need to be fed healthy food in order to concentrate and learn and work and thrive through jobs, which is where we often think about economic mobility, but jobs that have opportunities for growth and a living wage and health insurance. And then much more broadly through community economic development and how we can make sure that money is staying in the local economy, that we're building local businesses, and that we're supporting each other in that way. And so I'll stop there, but just a quick highlights of some of the things that I'll talk a bit more about as we move through the discussion.
Great, thank you. Well, let's jump in from there and really talk about, unravel a little bit this relationship between health and economic prospects. Jerome, I gave those stats at the beginning, which really had to do how health impacts work and productivity, which leads, to economic mobility, but it works the other way too, right? One's economic well-being impacts their health. And so can you give us a little bit more on this sort of interdependence between the two?
Yes, I agree with you, Byron. It is a bi-directional kind of conversation, right? So in order to be gainfully employed, you have to be healthy. But in order to be healthy, there's a lot of data to support that upward mobility, access to jobs, et cetera, is also very important to one's health. And when you look at the CDC, definition of the social determinants of health, which is are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. They use a framework that's a place-based framework, meaning they look at healthcare access, education access, social and community context, neighborhood and environment, and last but not least, economic stability. Economic stability is definitely a connection between financial resources that people have, their income, cost of living, socioeconomic status, and their health. Now, at Novant, we are interested in tackling a number of different social determinants of health, but some are more a priority than others. And the four that we really focus on, obviously healthcare access, we're a healthcare system, but we also focus on food insecurities, housing insecurities, and upward mobility. Now, when we look at some of the intersection of health and upward mobility and economic mobility, we actually have to start with our employees. Why? We are a large employer in the region with about 33,000 employees, and these employees live in the communities that we're talking about. And so first and foremost, we believe in an increase in compensation for Novant Health employees. Some of our lowest paid workers, we believe should have an uplift in the living wage. And so we've increased our living wage to $15 an hour, which represents about a $4 million investment into our team members, because we have to really start at home first before we move out into the community. Another one of our programs that we're really very supportive, proud of, is our upward mobility program. And in our upward mobility program, what we've done is, once again, we've taken our medical assistants, who are typically on the lower end of the earning scale, who have interest in becoming a nurse, and we provide a scholarship for those individuals. When I say scholarship, I'm not only referring to scholarship dollars to support tuition for nursing school, but also providing them with life navigators, providing them with nursing navigators, providing them with salary and benefit support down to 12 hours. So meaning if they reduce their hours down to 12 hours per week, they still maintain their compensation and full benefits as they go through nursing school. And then after graduation, we have a placement for them within the institution throughout our system. Now, as we go outside of the walls, we also truly believe that healthcare institutions are anchor institutions in communities. that those institutions or anchor institutions should not only provide employment for individuals in the community, but also invest in different economic activities in the community. So we're committed to bolstering upward mobility of women and minority-owned businesses. And since about 2006, we've invested about $1 billion in women and minority-owned businesses and vendors that we do business with in a very intentional way, because once again, we understand that creating economic opportunities for different businesses, for different individuals in the community, not only will set them up for economic success, but will also set them up for healthier lifestyle. And then lastly, I also want to share that this type of activity requires partnerships. It requires collaboration across the community, and that's why I'm grateful for this conversation today. Our community health worker program. When we look at community health workers, they are trusted individuals that typically come from communities that they serve. And what do? They connect individuals to health and human resources in order to support their needs. Some of them are housing needs, some of them are economic needs, some of them are health needs. Now, how do we work as a community to collaborate in this effort? Well, we've created an ecosystem. So we've worked with Charlotte Works to identify individuals from the communities that we want community health workers to work in. Those individuals, after they're identified, we have a partnership with CPCC where they go through a certification program to become a community health worker, whether community health worker 1 or 2. And then after they go through the certification process, training process, education process, we then hire them back in our institution to work in the communities that we're serving to connect them to those health and human services. So creating an ecosystem in collaboration with different entities across the community. And I underscore collaboration, partnership, and connecting the dots, because it's not one sector, it's not one industry that's going to solve some of the challenges that we see across our community, especially those challenges that affect those that are most vulnerable in our communities of color.
Very good. Thank you, Jerome. I want to just remind our viewers and audience that we really would love you to participate. If you have a question that you'd like to pose to any of the panelists, please drop it into the chat, and we will make sure we leave some time to introduce those questions and get some feedback as well. Kinneil, this connection between health and employment, Jerome touched on this, but Atrium is the largest employer in Charlotte. And so I know your work, while focusing on social determinants, you have this unique perspective as an employer. And I'm wondering, what are you learning as you, in what's Atrium learning in its exploration there, and how is that informing the strategies for the health system?
Yeah, so I think over the last year, we've always had, a myriad of programs to support our teammates, but I think over the last year, we've been doing a lot of soul searching around how can we stand up more robust supports, recognizing that sometimes those challenges that show up out in the community translate over to our teammates and make it harder for them to be able to focus on their work when things are falling apart outside of work. We've also, over the last year, been architecting what we're calling our social impact strategy. And I can talk more about that as the conversation unfolds, but it's really focused on extending the life expectancy in our most underserved communities in our catchment area. And so we employ a lot of folks from our most underserved communities. And so we really made a choice to start there, because when we step fully into our power as an employer, there's actually a lot that we can do. And so we've been, over the last year, piloting our social impact strategy for teammates. So I'll kind of tell you about some of the things that we've done. And I'll say, it's not something that we can do alone. It's really by virtue of the fact that the Charlotte-Mecklenburg region has a really robust set of strong community-based organizations that we've been able to lock arms with. So we actually did a survey of our teammates in some of our lower income job bands to understand what supports they may need. We've stood up a career development center in recent years that is prioritizing moving folks from some of our lowest income job roles up in various career ladders in the most rapid ways into higher earning roles. Of course, we're doing all the things around minimum wage and that kind of thing. When we made the investment in affordable housing, so some folks on the call may know Atrium Health invested $10 million in affordable housing in recent years. We prioritized being able to allocate affordable housing for our own teammates. And so we call that the HOPE program, Housing Opportunities Promoting Equity. Our teammates have an application process for that where we connect them with affordable housing options. And then, post-COVID, we actually stood up what we call the Teammate Help Now program. Dr. Dawn Jonas on our team oversees that program, but it's just been fantastic to work with some of our local partners like Loaves and Fishes and Second Harvest for our teammates that express support around food needs. Crisis Assistance Ministry has been a phenomenal partner just to help with whatever needs that our teammates have expressed that may need some of that deeper case management support. Digital Charlotte has been helping us connect the dots in terms of digital gaps, the digital divide that we all talk about for our teammates. And then Dream Key Partners has been helping us with, so many of our teammates have just said, I want to become a homeowner, and we want to connect those dots and what we've learned. So Dr. Jonas just shared the statistic with me yesterday, so I'm going to share it with all of you today. We had 85 teammates that went through our program partnership with Dream Key Partners, and 50% were unaware of the financial assistance support to help them become homeowners or assistance to help them stay in their homes. Half didn't know that they could improve their credit. And so those are the kinds of things that when you start to ask a more intentional set of questions through your role as an employer, you start to realize how folks may not be aware of the social support ecosystem in their own communities, and how we as an employer, through that relationship, can start to connect those dots and then really holistically wrap around teammates. So, the bet that I'm making is, if you become an employee of Atrium Health, that in time, we're going to support you in a very wraparound way to move up economically. And so that's a big part of our goal. I'll get more into that in time, but that's how we're thinking about the work in a very aggressive way.
Wow, that's exciting to really be measuring that advancement among your employees and applying, as you said, the leverage and the power of the organization to move that. Colleen, I'm thinking as I listen to Jerome and Kinneil talk about these really forward-thinking ways of addressing the issue and this connection between health and economic well-being, that while we're addressing it with these innovations now, this is not new, and these current conditions didn't just come upon us, right? They're rooted in really long-standing social structures around work. I wonder if you might share a little bit about that.
Yeah, absolutely. And I think I'm enjoying hearing about the initiatives from both Atrium and Novant as well, and the integration of so many services, right, that are critical to people's lives. But it's correct that today's challenges in health and food and economic mobility are not brand new. They weren't all spurred during the pandemic, but are rooted in historic and systemic injustices. As a special issue I recently co-edited for Human Geography on food geographies illustrates, these injustices can be traced back to systems of slavery and colonialism, through to segregation, patterns of white flight and urban renewal in the 1960s and 70s, and decades of disinvestment in communities of color that has now made neighborhoods ripe for gentrification. Charlotte has a long history of racial segregation. Tom Hanchett recently released a second edition of his book, Sorting Out the New City, where he details what he calls, quote, the reordering of residential patterns in Charlotte at the turn of the 20th century, through which Black storekeepers were shunned, landlords were pressured to evict Black tenants, and suburban developers wrote restrictive covenants limiting ownership and residence to only white residents. These patterns of segregation and discrimination continued for decades, even through less overt mechanisms once laws were passed to prevent discrimination in housing. And these patterns don't just impact where people live, but all measures of quality of life and opportunity. Today, a person's zip code in Charlotte can tell us a lot about their life expectancy, right? As some of the maps from Quality of Life Explorer you were showing at the beginning demonstrate. And that is because, in part, the only neighborhoods where residents of color have been able to find homes are the same neighborhoods where access to food and healthcare and quality education and transportation and green space are limited. And again, according to Hanchett, as city council has made decisions about where to locate community facilities throughout much of the 20th century, they have focused much more on the wealthy suburbs that were growing in Charlotte and not in Uptown and the Crescent. And we see the impacts of that today. And these systems are also part of the social determinants of health and all of those needed services that the other panelists have been talked about, and they represent areas of needed institutional investment. Many neighborhoods have been left behind with negative consequences for the health and the mobility of their residents. Although I don't want to forget to say that this does not mean there are no assets in these neighborhoods. Residents and community leaders in neighborhoods that have been disinvested throughout Charlotte have fought through incredible adversity to address neighborhood needs, and their work needs to continue to be lifted up and supported. And one of the last things I'll say is that, the systematic disinvestment in neighborhoods is often made visible through the closing of grocery stores. Throughout the country, grocery stores have left communities of colors that they deemed to not have enough spending power to keep the companies profitable. Dr. Shante Reese, an anthropologist at UT Austin, wrote about the correlation between unhealthy food environments and communities of color, particularly evidenced in a lack of full-service grocery stores in her book, Black Food Geographies, which focuses on DC, but I think can tell us a lot about neighborhoods all throughout the country. And the environments that she talks about are produced through processes that are increasingly referred to as supermarket redlining. And in order to make clear the systemic forces at play in producing these inequalities. Here in Charlotte, we can look to the West Side and the closing of the Wayne supermarket in the late 1990s. And the fact that despite numerous efforts for decades by community leaders, that store and earlier versions of it as a Harris Teeter has not been replaced. And so it continues to be a neighborhood where residents must travel very long distance in order to get access to fresh and affordable foods. My research has shown a consensus that when residents aren't able to access and afford nutritious foods in their neighborhoods, it impacts their health negatively. It makes it hard to concentrate on school and work. And it adds additional stress and time pressures to their lives in ways that limit their chances to grow and thrive and pursue that economic mobility.
Yeah, that's yes, it's interesting as you talk about these systems that impose those barriers. I want to, Jerome, ask you, continue that way of thinking a little bit, and I want to interject an observation and question that's come through the chat from Anna Casey, and just encourage others of you listening, please, if you have a question or thought to pose to the panel, please drop it in the chat. But Ms. Casey notes that previous surveys have found that oftentimes clinicians don't make the connection between race as a social construct, and so they make decisions, care decisions, and false assumptions based on their own biases. And she really asked, what responsibility does the health system have to address that issue among its caregivers? And I as a practicing clinician, I wonder if you could share about that and other kinds of systemic rules and regulations. What's the role of the health system really addressing those embedded systemic barriers as it relates to providing greater economic opportunity?
Yes, that's a wonderful question. So first and foremost, I think that our role is a role that is not a healthcare role, but a societal role, right? Because as Colleen mentioned, a number of these inequities that we see in our communities are from rules and regulations that are not directly related to healthcare, but have a significant impact on one's health. So let's just look, for example, let's just go back a little bit. Let's look at health insurance, right? So health insurance came about somewhere in the, I guess, 1930s and 40s. Please correct me, Byron and Colleen, if my dates a little bit are off. Came about during that time as wages became stagnant. Employers offered health insurance as a benefit to attract workers and retain workers. But interestingly, health insurance was not universally available across sectors, right? So typically jobs that were for white men, they received healthcare insurance, but those that employed women, people of color, such as agricultural, hospitality, retail, there was no health coverage available for them. So as we've now progressed from the 40s and 50s to the current state where retail service jobs have exponentially exploded and have a large portion of people of color in those roles, you have a pandemic hit, right? And there's either loss of jobs and or illness and no health insurance, right? So you can see how something that occurred back in the early century has a profound impact today. To get to the direct question, first and foremost, I think healthcare systems should have a leadership and advocacy role. Okay, leadership and advocacy role. Why do I say first and foremost? I say that because the problems and challenges that we're discussing really are not, quote, healthcare initiated challenges. We see the end result being a number of healthcare issues. But as I said earlier, we're an anchor institution. We're a public trust, just like universities, and we should be exhibiting leadership, adaptive leadership, pulling folks together in conversation and advocating for what is appropriate for our communities. And that advocacy also should venture and lean into policies and regulations and things of that nature. You know, I know historically institutions of education, institutions of healthcare are usually somewhat conservative as it relates to advocacy for political changes. But we're at a time now where our communities are suffering, and we really have to advocate for the changes in a collaborative fashion that we know are impactful for our community. Now, on the provider side, we absolutely have to have cultural competency. We have to have cultural sensitivity to our communities. We have to understand our communities. We have to have workforce that looks like our communities. There's tons of data that show the health of individuals are improved when they have folks that look like them. Now, I don't believe it has to do with race. I believe it has to do with culture, right? It's not a color thing, it's a culture thing. Understanding the culture of communities, understanding historical eating habits, understanding historical engagement is very important in understanding the communities that we deliver care to. So we should be in the forefront, leading, advocating, and then also educating our workforce to understand how to deliver culturally competent care.
Kinneil, I wonder if you might want to jump in from a system perspective, especially in light of the issues of these tensions of race, class, you know, a lot of the racial justice protests and the pandemic, how this role of advocacy from a system vantage point, what is your thinking about that and how are we doing?
Yeah, I'll try to blend that question with the question from the audience member. I agree with Jerome that I think there is an advocacy role to play. I think operationally there's still some things that healthcare systems have a really important responsibility. You know, the question around race being a social construct, we could have our whole panel just about that and spend days talking about that, because as I'm sure many on this call know, there's really no biomedical or genetic basis to race. So in that regard, it's a social construct. However, we do see a lot of patterns playing out in terms of health outcomes by what we've deemed the category of race, again, being a social construct. And what we find, you know, I think to Jerome's point, is that culturally and because of historical reasons, folks engage with the healthcare system differently. And we have a responsibility to monitor that, to ensure that we are providing equitable, not just equitable care, but more importantly, equitable outcomes, which may mean that we actually need to tailor our care to the unique needs of particular populations and communities. And in order to do that, I think one of the #1 things we need to do is collect good data. And so over the last few years, Atrium Health has gone through a pretty intense process to clean up our race and ethnicity data, again, acknowledging the social construct nature by moving to a patient self-identification model. So instead of a patient showing up and being eyeballed and assumed what their racial identity is, we ask the question, and we have 50+ options for patients to self-identify based on how they see themselves in the world. And then we map them to these broader bucket categories when we need to, but that allows us to do some pretty sophisticated analyses to guard against healthcare disparities. The other piece of that, you know, there's a lot of things in the literature around racialized medicine and African Americans being prescribed different drugs and doses than whites, and there's tons and tons of controversy. I won't go into the deep end of that now, but I'll just say, I think we also have the responsibility to educate our workforce. I've taught in medical schools, I've taught medical students on this, and so I think it's really important at ground zero in medical school, but throughout their careers, that we're educating providers on unconscious bias and how that can actually show up in their prescribing patterns, their patient interactions, how they can moderate some of the challenges that may come up around lack of racial concordance. And then I think, Byron, to your original question, more broadly, you know, we're not doing that well as a society around improving inequities around race. We've made some progress, but we've still got a long way to go. And unfortunately, COVID has sort of smacked us in the faces around the persistent inequities that in this pandemic have really literally determined who lives and who dies, right? That is the ultimate unfairness. And so, you know, at least on our end of things, I think we already felt like we were doing a lot, but I think we've gone through some serious soul searching in the last year. And so the social impact strategy that I referenced earlier, it resides on, if I were to show you a visual of it, the very bottom of it says that the whole strategy resides on deconstructing institutionalized systemic racism. Right. And so everything we do, we try to bring a race conscious gaze so that we are addressing how structures can almost mindlessly replicate racism. And so that we're counterbalancing that in a race conscious way with how we design our programs and our interventions. And it's really radical new way of thinking about the work. But, you know, when we've intervened around COVID, everything we do, everything we look at through the lens of race, the partnerships that we build in the community. We are being very intentional about that, and unapologetically so, because I think we can all agree that the unequal outcomes around this pandemic, those of us that have been working on health justice work for a long time, this was no surprise to us. We saw this coming because of the persistent inequities. So we have to bring this race conscious gaze, I think, to our work in the future.
Yeah. You know, Colleen, I'm along those lines, I'm looking at this, the comment in the chat from Stephen Balder, who notes that, you know, we can measure outcomes, but it's really about how well we're addressing them and the action that leads to equity. So as a researcher, as you're looking at this intersection between health and economic mobility, through food security and other issues. Are you seeing tangible solutions emerge, real action taking place, and what are they?
Yeah, thanks for that question. And I think that some of the challenges here with those solutions is that they're complex, right? That there is no silver bullet to solve these problems. And so, my research specifically looking at food has shown that a healthy food system is necessary for economic mobility. The food system can provide well-paying and respected jobs and decrease income inequality. It can build community assets through food business ownership and enhance social capital through food systems relationships within communities, including through various feeding programs. But it doesn't necessarily do that, right? We have to work with the system, improve it, make it stronger so that it achieves those goals. And so we need more complex and nuanced solutions that recognize that interdependency of the social determinants of health that have been discussed on this panel. I'll say participants in the state of the plate research that we've been doing emphasize that the food system has the ability to provide jobs. But as Jerome noted, those service sector jobs don't necessarily achieve those economic mobility goals for people. Not just any job is going to do. Instead, we need investments in food systems jobs across the system so that they are living wage jobs, so that they offer opportunity for advancement and wealth generation, and that they provide benefits like sick leave and health insurance. For example, one of the respondents to our surveys explained that if we focus on urban farming as an example here, and how do we make that a viable profession for diverse populations? And you can teach someone how to farm, you can teach them how to run a business, but in order to be successful, they're going to need to acquire land. And so to support that, we must look back at these systems that have limited land ownership for farmers of color. We must celebrate the cultural connections to land for Black and Indigenous communities, and we must build on the expertise that they have. And so in short, we must address some of the systemic barriers we've been talking about. And if families have access to these sorts of opportunities, jobs, a living wage, the freedom to, quote, achieve the quality of life they desire, as one respondent defined economic mobility for us, and food resources are made more readily available, then they can acquire the nutritious foods needed to grow their lives and pursue that opportunity. And then the last thing that came up in our research is really critical, is harnessing food systems in order to build community economies. And this happens in multiple ways. On the one hand, if consumers spend their food dollars at farmers markets or local stores or restaurants, then those dollars are more likely to stay within our community, right? Then those farmers and restaurants and store owners are more likely to spend their dollars back in our community. At the same time, for many, a grocery store is more than just a place to purchase food. And that the solution in all places may not be just put another Harris Teeter there, but instead thinking about grocery stores as places that are resources for the community in many ways, that they're gathering places, they provide these jobs that we've been talking about, and they can do nutrition education in addition to making that food available for folks. Others pointed out that grocery stores often serve as an anchor for a shopping center or a neighborhood, such that having a vibrant resource like that can lift up the other facilities surrounding it. And so we need more investment in those sorts of resources in neighborhoods overall. At the end of the day, many participants in my research pointed out that food systems impact economic mobility because they're connected to everything, right? Food is the most personal thing somebody engages with every day in order to survive. And people make many choices that impact their bodies and communities in acquiring the food that they need. They choose what to eat, they choose where to spend their money, and how to balance competing costs such as housing and medicine, transportation, and food. And so ensuring a strong local food system to which everyone has access and everyone has a say in how they participate in it is critical to achieving these health and economic mobility goals.
Byron, can I jump in for 1 second? I just want to highlight something that Colleen said that, when you look at healthcare coverage, right? There are 37 states as of June that adopted the Medicaid expansion under the Affordable Care Act. North Carolina was not one of those states, was not. And so something as simple as that, when I spoke about advocacy, right? Something as simple as that provides health insurance, Medicaid for those most vulnerable, that takes away a big financial outlay as it relates to getting health care, all right? And getting health care services. So you talked about systems, you talked about structures. That's something that is very important for all of our citizens of Mecklenburg County and citizens of North Carolina to really look at why have we not expanded Medicaid? Obviously, it's political. We all know the reasons, but these are the things that while will not solve all the problems, can go a long way, and I think everyone can get behind.
Yeah, I think I was looking, Jenny Hutchison asked this question about access specifically and how that interacts with race and economic mobility. And I think what you're talking about is an example of that interaction. I also Colleen, you were talking about the sort of economic spin-offs and connections related to food and the food ecosystem and how that impacts economic mobility and the investments there, both Kinneil and Jerome have talked about, as well as training and development for employees. Bill Brandon asks about really the investment and connection with post-secondary career development and how lower income folks might, through post-secondary education, through community colleges, as Atrium develops its medical school, what are the opportunities and what are the ways the health systems are investing in that kind of post-secondary career development toward particularly those higher paying jobs and roles within the health system?
You know, I can jump in and Jerome,
Yes.
Please do so as well. I would say, I think we're being really honest with ourselves about what are the potential derailers that might get in the way of a very well-intentioned member of our workforce who wants to grow their careers, who wants to go back to school, about what may be those things that get in their way. And those things that get in their way may be things outside of Atrium Health's traditional control as an employer. And I'll use one of our own teammates as an example, because we love to start our meetings, all of our meetings, including our board meetings, with Connect Purpose. And we're about to share one of our teammates who is in, it's our RN scholarship program. And it's one where we essentially pay folks to go to school full time, but work for us. We front load their tuition. So sometimes, you know, in order to prepay your tuition and get reimbursed through traditional tuition reimbursement programs, puts higher education financially out of reach for folks because they just don't have the cash to front load that tuition or prepay that tuition. So we've started doing that for folks that we know can't afford to do that. We front load the tuition. We enroll them in our career development center to have a coach who's really going to support them with all of those derailers, just the blocking and tackling that may pull them out of school. So we had a teammate, she had a pregnancy in the middle of her RN program, you know, and for anybody that knows about RN programs, they're incredibly intense and fast paced. That could have easily pulled her out of the mix, but we kept her in. She needed help with food security. I mean, she was struggling because she wasn't, you know, able to put food on the table at certain times. We helped her with all of those things. And so now she just passed her NCLEX. She's going to be a nurse at one of our facilities. And, you know, and that's actually something we really need right now during this pandemic, is more nurses in our facilities. But I share that as stories. That's part of our philosophy now. So it's not just about a tuition reimbursement program, but it's really about these holistic wraparound services that really meet our teammates where they are, help them identify what their derailers might be, and then support them on that trajectory. But we also recognize that the path to economic mobility may not be universally about higher education. It may be about moving up economically into different jobs that may just require a certification. Sometimes we can engage with our partners like CPCC on some of those. And so those are the things that we're working through. I could probably share a lot more examples, medical coding programs, things like that. But supporting folks in fast tracking into higher earning roles.
Kinneil, one part of Bill's question was what, beyond those sort of employee level efforts and programs at statewide or national levels, is Atrium engaged in advancing opportunities like free community college or other kinds of more system efforts around more equitable education, particularly in the fields that impact healthcare?
Yeah, absolutely. And so we actually sit on several national councils that are meeting with lawmakers at the national level, and of course on the state level as well. We've worked with Senator in South Carolina to set up an apprenticeship program. That's been, the research shows that's been a really powerful way to achieve economic mobilities that states can invest in. So we're actively working with our lawmakers to figure out innovative programs that we can lock arms with to help. And I see the question about lobbying muscle. Absolutely. Like, we want to support, we are now very consciously aware that just the traditional lobbying positions of health systems, which tend to be more myopically focused on, healthcare related topics, are just not enough when we recognize the role that these social determinants of health plays, and not just higher education, but we've not historically showed up at the food policy party and the housing policy party and all of these other advocacy centers that really the decisions that get made there have huge impacts on the health of our patients. So we need to be joining these coalitions, using our advocacy voices in a much broader way. And we've actually, the meeting that I had right before this was to review our social impact advocacy positions and kind of start to get lawmakers on record on some of these areas where we're seeking to impact health equity in our communities.
The only other thing I would add to that is that it is important to understand that you build equity in every aspect of your organization, right? It's not a program, it's not a project, it's not a work stream. And over the last decade, we've intentionally built DI&E throughout all of our departments, and actually have each and every department presented at Health Equity Council their gaps, and then what are they doing to resolve those gaps. Now, why is that important? Because if you think about hiring in an institution as big as UNC, Novant, Atrium, the talent acquisition department can't really control every aspect of every individual being hired from a cultural standpoint. However, if every department, if every division understands that DI&E is front and center to what we do, okay, then each and every one of those individuals who are in positions to hire, to recruit, to retain talent has a lens of equity during this process. That's number one. And number two, Kinneil mentioned this earlier about looking at job descriptions, right? So our people talent acquisition, formerly called HR, we're looking at our job descriptions. So job descriptions that formerly require an MBA or a higher level of education. If an individual meets if an individual meets qualifications because of service, 10 years, 12 years, 15 years, but they may not have an MBA, they may be a person of color, maybe a woman or other minority group, we want to look at that to make sure there are opportunities being afforded to all candidates and not eliminated because of an arbitrary degree that may have been put on the books 15, 20 years ago that might not be applicable to this day and age. I think Kinneil mentioned there are many certifications out there where people are gaining skill sets outside of the formal degree process. We need to look at that for much of our community as well.
You know, we talking about this impact, this interdependency between health and economic mobility. You know, Nadia Anderson notes in the chat that there are all of these aspects that really work interdependently: food, housing, and you know, Jerome, at the beginning, you mentioned those, I think, 4 focus areas: housing, food, upward mobility. How do you manage them and so that they aren't these siloed initiatives and programs, but are more integrated, particularly as they're implemented at the neighborhood level? Is one of the questions that Nadia has.
So it's really about connecting dots and not reinventing the wheel. I've had the pleasure, as well as Kinneil and Don as well, Don Jonas, to serve on the Charlotte Mecklenburg Housing Homelessness Strategic Work Group. Why is that important? Because in order to address, and we're talking about upward mobility, but it's still the same for housing, homelessness, and other social determinants of health, we realize that they're interdependent, right? You cannot talk about housing security, you cannot talk about the undomiciled unless you talk about health, wraparound services, upward mobility. So it's really about connecting the dots with strategic partnerships, leveraging subject matter expertise in particular areas, and bring that to the table and understand how does that dovetail with other sectors. So for example, we're healthcare. We are experts in delivering healthcare. We're not experts in food insecurity. However, we understand the linkage, and so therefore we partner with our local food banks, we partner with Loaves and Fishes, we have food pharmacies within our community access clinics. Now, while our food pharmacies and mobile food pharmacies are in our clinics, they are run by the subject matter experts that we've partnered with, because they do it and they do it well. And so it's really about developing strategic partnerships to create greater impact. And that's through conversations, that's through meetings such as this platform here, that's with engaging with each other in a meaningful way to understand where there's common value that we bring, that we receive and that we bring, so that we can create a greater impact. So it's really about connecting the dots, Byron.
Yeah. Colleen, I wanted to come back to you as well on it's a question, another question that Anna Casey has posed on economic impact as it relates to time as a limiting factor. And this, you know, obviously shows up in the burden and time for shopping, you know, preparing meals, cooking, particularly for single mothers or caregivers, and that may impact their ability or capacity to develop their careers, work a stable job. And so there's this tension between healthy food, preparation, and economics. And could you speak to that? And is that something that you're seeing in your research?
Yeah, it's a great question, right? And I think it again plays into the complexity of this challenge, right? And that simply getting somebody food in one way or another doesn't necessarily solve the problems of food insecurity. That it's a complex issue that involves time and resources and knowledge and equipment in your kitchen and a lot of things. And so in terms of how we address those issues of time, right, certainly some of that's the locating of grocery stores and the locating of transit to and from grocery stores, and ensuring that people are able to get to the food that they need and able to bring it home. If you've ever shopped by a bus, that's not grocery shopped by a bus, you can't load an entire trunk's worth of food into your car and drive that home. You end up carrying smaller bags, so it means more trips to the grocery store, different kinds of foods that you can purchase. And so one of the solutions there is really thinking about that transit burden for folks and how we lift that. And I would say that's true for shopping for food, but it's also true for things like accessing healthcare and how we work through that transit burden for folks. And then really, not only does prep take time, but it requires that you have a full kitchen inside your house. If you're being told the only way to get healthy food is to bring fresh vegetables home and prepare them into a meal. And a lot of folks who, I work primarily in the immigrant community, and there you have a lot of folks that may be several families in a house that are sharing one kitchen. We have a lot of, housing folks who are facing housing instability, who are living in hotels. And so what does the ability to prepare food look like for those families when they don't have access to a full service kitchen? And so I think really some of the solutions there are understanding better what people's current strategies are, how to make those strategies more sustainable, right, and more effective and efficient, and how to kind of meet people where they are and devising the solutions that we're coming up with for food insecurity. I'll also say when we look at the institutions and the support for people in terms of WIC and SNAP and some of those federal assistance programs, there's some gaps there, right? You can't purchase hot food with SNAP, which means that the only food you can get is stuff that you have to take home and prepare. So when you're doing all of those different jobs, that gets a whole lot harder to be able to use those benefits in the way that people are being told by nutritionists they need to be able to use them.
Yeah, that's interesting insights. I want to get to question from Ricky Hall, and it's interesting. So, and he talks about the community health worker model, which I know is health systems have invested in, and I think Ricky's asking about how receptive are that systems to really thinking more about these support models as more cooperative, more community owned, more entrepreneurial than service oriented in terms of providing community health, and sort of a different way of supporting economic mobility through the very service kinds of programs that exist. I'm wondering, Jerome or Kinneil, are there tactics or efforts underway that you all are thinking about along these lines?
So, I'm sorry,
Go ahead, Jerome, go ahead.
Yeah. So a couple things. One, community health workers is a very targeted type of activity, right? So that's an individual that ideally is from the community that they're going to serve, that are connecting individuals to health and human services. So very targeted type of activity. What I think Ricky may be alluding to, and please, Ricky, don't let me put words in your mouth, is more of a navigator of sorts that go outside of just health, right? So a navigator that could support individuals as it relates to business development, connecting them to business opportunities, entrepreneurial opportunities, et cetera, et cetera. So yes, I do think there is an opportunity there. I think there is always an opportunity to connect individuals to programs and services that already exist that they may not even be aware of, whether that be a community health worker, whether that be a life navigator, whether that be navigation services. So yes, I would love to continue this dialogue offline, Ricky, and hear some of the thoughts. I will also add that most of the really good thoughts, great thoughts, actually come directly from the community and not from big institutions. The folks in the community really understand what's going on the ground level. It may require investment, may require a business plan or some other type of executive in residence, but often my experience is when you go in and engage and meet with the community, they already have the answers there. It's just, how do you implement them?
Kinneil, did you want to jump in?
I think Jerome covered it really well, other than I would be happy to. I mean, we have a community health worker program with Ricky's organization, the West Boulevard Neighborhood Coalition, and I was happy to see Ricky on here. As I think got a lot of visionary ideas, and I think, in terms of the health system, to Jerome's point, I think it's important for us to follow the wisdom of the community wherever that leads us. I think we're very interested in wealth building in underserved communities in the many ways that can manifest through organizations, land trusts, our supply chain by purchasing from businesses in those communities and helping those businesses grow. So, I mean, we kind of got on this conversation because we're talking about the connections between wealth and health. And so for us, we want to curate those opportunities where we're following the community around how the community aspires to build wealth, and then we're using the power of our economic weight to put some, where appropriate, where the community wants that support, to kind of galvanize and support that.
So we really need to start to wrap up here. And so let me ask you each if you could briefly give, in your own way and from your vantage point, an assessment of where we are. Lots happened, especially over the last year and a half with the pandemic, with racial justice protests. Clearly, there is a great deal of insights and research that are guiding what you're doing, and a number of different kinds of efforts going on. So how are we as a community? How would you gauge where we are in whatever way you would want to express that? So Colleen, let's start with you.
I was just writing out a couple quick notes to make sure I remembered everything floating in my head.
Yeah, no, I said do it in 30 seconds and I made it 4 questions.
I would say that we have a long ways to go, right? My sense is that there's a lot of work that still needs to be done. Being somebody who has worked on food system issues for a long time, and as Kinneil mentioned, the inequalities that surfaced to the top during the pandemic were not a surprise. They are things that we know have been going on in our country and our city for a very, very long time. And so, it's, I think, perhaps a positive that it's at the forefront now and people are seeing, right, all of the injustices that are here. But I think, not to end on a totally pessimistic note, I think there's some work to do to really figure out how to solve those issues. And I think one of the key pieces that was coming out here at the end too is how we meet people where they are and how we harness the expertise of community residents, of community leaders, of those who have ideas, and we need to support them and help them bring those ideas to fruition.
Great, thank you. Jerome?
I'd have to echo what Colleen says. I think that for those of us, and that's pretty much everyone on this call here on the panel, for those of us who've been engaged in this type of work for decades, it's never enough, right? We're way behind, right? However, I will honestly say that because of the pandemic, what was previously in the world of folks working in equity space, health equity space, is now common knowledge, right? You can't hide from it now. You can't say, I didn't understand inequities, disparity. It's now front and center. So for that, I am extremely excited because now we're galvanizing around a topic as a community, public, private, not-for-profit, are really pulling together to find solutions with the communities, not for the communities, but with the communities that we serve. And so I see that as a huge stepping stone. But as a physician and someone who's been in this work for a while, it's never fast enough. I'm sorry. I want it done yesterday.
I think we can all appreciate that. Kinneil, your final thoughts on where we are.
I'm wanting to be optimistic, so I'll try to land there at the end. But Desmond Tutu, who's one of my personal heroes, he wrote a book about the Truth and Reconciliation Commissions in South Africa. It's called No Future Without Forgiveness. Great book if anybody has the time to read it. But he devoted a chapter to, he called it "We Did Not Know," and it was really about a lot of white South Africans just sort of proclaiming that they didn't know how bad our apartheid had been for Black people in South Africa. And he talked about how sort of the whole society had been almost organized to sort of insulate white South Africans from the harshest realities of apartheid. I will just say, as somebody who's worked on this stuff for a long time, you know, I'm thrilled to see the awakening. I'm thrilled to see this more earnest commitment to racial justice and social justice and health justice. It has been really painful for me to have to realize that we got here because we all watched a Black man being suffocated to death on national television. I just don't think that we should have had to see something like that to have that kind of awakening. And I'm not saying it was just that. I mean, obviously the pandemic with all of its inequities, but I do believe that that was the galvanizing event that really caused this kind of national soul searching on the level that we're now seeing. That said, I have never seen a window open like this in my career. And for those of us that do this work, we need to run right through it. And that is what we're doing at Atrium Health. We're hardwiring our social impact strategy, which is all about justice and equity and better outcomes for all. That's really a part of our mission statement. That means a lot to us, but we're intertwining it so deeply into how our organization operates that even when the momentum and the awakening wanes, that we're still going to be there doing this work. And so I think that's the commitment. You know, we're in it for the long haul, whether it's the topic du jour or not.
Thank you. First of all, you can't go wrong concluding with Desmond Tutu's wisdom, but the theme I hear in all of your responses and in the remarks through the chats is, you know, awareness requires accountability, and accountability demands action. And it's great to have three committed leaders in our community who are, in fact, moving in terms of action and leading that way. So Kinneil, Coltman, Jerome Williams, Colleen Hammelman, thank you for joining us for this conversation. Thank you all for sticking with us. Please join us again next month for the next Shul discussion, which will be virtually. It's going to be on September 30th, and we're going to talk about economic mobility from the vantage point of the racial wealth gap. Keith Cockrell and Dr. Derek Hamilton will be joining us for that. There will be an October conversation. Stay tuned. We'll get you the details on that. We're still working on speaker availability. And then the Shul Forum, our annual event, will be November 18th. That will be in person. As of now, we're hoping that holds up. The details to come, I can tell you it's going to be exciting. However, we go forth with that, and we really hope you'll join us. So thanks again for being a part of the discussion today. Thank you to our panelists. I'm Byron White at UNC Charlotte and the Urban Institute, and we look forward to talking to you next month.